So, what if I told you that the secret to really understanding blood pressure, edema, and even shock all comes down to a journey that's smaller than the width of a single human hair? Well, if you're a nursing student, you are in exactly the right place. We're about to follow one single red blood cell on its critical mission, and I promise by the end of this, you're going to feel like you've totally mastered microcirculation, not just for your exams, but for your clinicals too. All right, you ready? Let's do this.
Okay, here's our game plan. First, we'll get why this tiny delivery service is such a huge deal. Then, we'll meet the traffic cops of the system, the arterioles. After that, it's the main event, the exchange zone and the capillaries. We'll follow our hero home through the venules, and then, importantly, we'll look at what happens when this whole system breaks. And of course, we'll wrap it all up with a super fast review to make sure it all sticks.
All right, let's meet our hero for this story. We'll call her Ruby the red blood cell. She's just been shot out of the heart, and her entire purpose, her one mission in life, is to deliver oxygen to every single tissue in the body. Whether she succeeds or fails, and this happens billions of times every single second, is the absolute foundation of what we call patient perfusion. Honestly, her journey is everything.
Have you ever wondered what really controls a patient's blood pressure from moment to moment, or why a patient with heart failure gets those puffy, swollen ankles? I'm telling you, the answer to those questions, and so many more, is hidden right here, in these microscopic blood vessels. Understanding microcirculation isn't just a topic for an exam, it is a nursing superpower.
So, here is your mission, should you choose to accept it. You are going to shadow Ruby on one single delivery. We're going to see how the body just brilliantly manages to get this one tiny cell exactly what it needs to live. This is not textbook theory, my friend. This is physiology happening in real time.
So, our journey begins. Ruby's just left a big artery, and now she's heading toward the first major checkpoint, the arterioles. I want you to think of these guys as the traffic cops of the circulatory system. They have these muscular walls that can squeeze down tight or relax and open up, basically acting like a faucet to control exactly which tissues get a fire hose of blood and which ones just get a little trickle.
And this brings us to a huge concept for your exams: total peripheral resistance, or TPR. It's a fancy term, but all it really means is the friction that blood feels as it's trying to get through all the pipes in the body. And here's the key takeaway. It's the arterioles, by either clamping down or opening up, that are the #1 controller of that friction. And that makes them a major player in your patient's blood pressure.
So who's in charge here? Who's telling these arteriole traffic cops what to do? Well, it boils down to two types of control. On the one hand, you've got intrinsic control. This is local. This is the tissue itself saying, hey, I need some help over here. If a muscle's working hard, it's gobbling up oxygen and spitting out waste like CO2. The arterioles nearby sense that, and they dilate. They open the faucet wide to bring in more supplies. But then, on the other hand, you have extrinsic control. This is the big picture, systemic command. The sympathetic nervous system can yell, everybody constrict, now, to almost all arterioles at once. This cranks up that total peripheral resistance, and it's one of the fastest ways the body can regulate overall blood pressure.
Okay, stop what you're doing. Here is your first NCLEX alert. Listen up. If you see the phrase total peripheral resistance on your exam, I want one word to flash in your brain like a neon sign. Arterioles. They are the main event. Got it? Arterioles. Good.
All right, time for a quick check-in, a little mini quiz to make sure this is sinking in. Ruby is cruising toward a muscle that's just, resting, not doing much of anything. Is that traffic cop, that arteriole, going to be constricted or dilated? Go ahead, pause here, and say the answer out loud. You ready? If you said vasoconstriction, you are 100% right. The body is so smart, it's not going to waste a ton of oxygen-rich blood on a muscle that isn't asking for it. It's going to divert that flow to where it's needed more.
Okay, Ruby made it past the traffic cops. Now she enters the most important part of her entire journey, the capillaries. People, this is it. This is the whole reason circulation even exists. This is the exchange zone. This is where the magic happens. The delivery is about to be made.
And just look at this neighborhood she's entering. It's not a single street. It's this massive, sprawling, web-like network. The total area here is enormous, and because of that, the blood flow slows way down. I mean, it goes from a rushing river in the aorta to a slow, lazy crawl right here. And that slow speed is absolutely critical. It's the only way Ruby gets enough time to unload her precious oxygen package. Now this great exchange happens in two main ways. First, you've got simple diffusion. Think of it like a trade. There's way more oxygen inside Ruby than in the tissue, so oxygen just naturally moves out. And there's way more CO2 waste in the tissue than in the blood, so the CO2 naturally moves in. Easy. But there's more going on. It's not just about swapping gases. The fluid itself, the plasma, is constantly moving in and out of the capillary. We call this process bulk flow, and its whole job is to keep the fluid levels in the tissues perfectly balanced.
And we really need to zoom in on bulk flow, because this is where so much clinical stuff comes from. I want you to imagine a constant tug-of-war happening all along the length of this tiny capillary. You can see the two opposing teams here. One team is trying with all its might to push fluid out of the capillary and into the tissues. The other team is desperately trying to pull that fluid back in. The winner of this constant battle determines everything.
So let's meet the star players in this tug-of-war. The main force on the push team is capillary hydrostatic pressure. Don't let the name scare you. It's basically just blood pressure inside the capillary. It's a physical pushing force. On the other team, the main pulling force is plasma colloid osmotic pressure. This pull is created by big proteins, especially one called albumin, that are stuck inside the capillary. They act like little sponges, using osmosis to pull water back in. Now yeah, technically there is some small counter forces in the tissue itself, but for the NCLEX and for the clinic, if you can master this battle, the push of hydrostatic pressure versus the pull of osmotic pressure, you are golden.
Okay, you know what time it is? Mini quiz. Looking at that diagram, what is the name of that main pressure that pushes fluid out of the capillary? Say it out loud. Did you say capillary hydrostatic pressure? Because that is it. That's your blood pressure getting the job done. Awesome.
So, mission accomplished. The delivery is complete. Ruby has successfully dropped off her oxygen, she's picked up the CO2 waste, and now it is time to head home. She leaves that capillary network and enters the next set of vessels, the venules. These are just the tiniest little veins.
And this image shows the difference perfectly. Look at the artery on the left, thick, muscular, ready to handle high pressure. Now look at the vein on the right, thin, floppy walls. We call veins capacitance vessels for a reason. Those floppy walls let them stretch out and just hold a ton of blood. Like about 2/3 of your total blood volume is just hanging out in your veins at any given moment. And that's critical. If your patient starts bleeding, the body can squeeze these veins to push that reservoir of blood back toward the heart, trying to keep the blood pressure up.
So we've seen the perfect journey, right? But as a nurse, you're going to spend a lot of time seeing what happens when this perfect system breaks. So let's connect all this amazing physiology to a real-world condition you will see all the time.
And that condition is edema. It's the clinical word for swelling caused by too much fluid getting trapped in the tissues. From now on, the second you see a patient with edema, I want your brain to immediately go back to that capillary tug-of-war. Edema is a flashing red light telling you that the push and pull forces are seriously out of balance.
I mean, just think it through. What happens if that push force, the hydrostatic pressure, goes way, way up, like in heart failure? Or what if the pull force, that osmotic pressure, goes way down, maybe because the patient isn't making enough protein? Well, the push team wins the tug-of-war, and there's not enough pull to bring the fluid back. So where does that extra fluid end up? It gets left behind in the tissues, and that, my friends, is edema.
Okay, you have absorbed so much information. Let's do a super fast, rapid-fire review to make sure the absolute most important facts are cemented in your brain for good. I'll ask the question, you just shout out the answer. No overthinking. Let's go.
First one. What are the vessels that are the main site of total peripheral resistance?
Arterioles. Yes. Number 2. What's the name of the pressure that pulls fluid back into the capillaries?
Plasma colloid osmotic pressure. You got it.
And last one. What do we call that excess fluid in the tissues from that broken tug-of-war?
Edema. Perfect. You are on fire.
Hey, seriously, take a second. Pat yourself on the back. You just followed a single microscopic cell through one of the most complex, intricate systems in the entire human body, and you connected it to real clinical stuff. That is not easy. You totally nailed that. You've got this.
So I'm going to leave you with one last question to really tie it all together. Your next patient has severe liver failure, and you know the liver's job is to make most of that protein, albumin. So, knowing everything we just talked about, what is the #1 clinical sign you're going to be looking for? And more importantly, can you explain why it's happening? Think about that tug-of-war. You have all the pieces now to solve that puzzle.
You guys are doing amazing work. Keep it up, and I'll catch you in the next one.